Welcome, everyone. I am Dr. Kilpatrick, representing the Arkansas Diabetes and Endocrinology Education Foundation, ADEF. Today, we will explore the Metyrapone Test, examining its clinical purpose, the underlying physiology of why it is performed, and the precise protocol for execution.
A patient presents with severe fatigue, weight loss, and symptoms of adrenal failure. Yet when their lab work returns, their Metyrapone stimulation test shows a normal result. Despite the paperwork, the patient actually has verifiable secondary adrenal insufficiency. For decades, the 250 microgram Metyrapone stimulation test has served as the first-line diagnostic tool in endocrinology. The mechanical flaw of this test is most visible in early or mild pituitary disease. The test relies on injecting the patient with a large dose of synthetic ACTH, bypassing the central brain signaling that normally regulates the system. This diagram illustrates the hypothalamic pituitary adrenal, or HPA, axis. When a massive external ACTH injection bypasses the pituitary and directly hits the adrenal glands, it forces a reaction. Even if those adrenals are partially atrophied from a lack of central stimulation, they retain enough capacity to mount a sudden, temporary cortisol spike. Because the adrenals temporarily wake up and produce cortisol, the lab results show a passing grade. This localized adrenal reaction masks the underlying failure occurring higher up in the hypothalamus or pituitary, generating a false pass. To accurately locate a central defect, an ideal test must challenge the endogenous production of ACTH. It must force the patient's brain to manufacture its own messenger hormone, rather than gauging adrenal capacity with a synthetic substitute. Passing a standard Metyrapone test proves that the adrenal glands remain sensitive to stimulation. It does not guarantee that the entire HPA axis is intact and functional. In 2024, the Endocrine Society and the European Society of Endocrinology released joint clinical guidelines prioritizing a more precise alternative, the single-dose overnight Metyrapone test, or OMT. This graphic compares the diagnostic sensitivity of both approaches. Clinical data published by Saoudi and colleagues demonstrates that while the standard Metyrapone test identifies roughly 60% of mild secondary adrenal insufficiency cases, the OMT identifies 100%. The core advantage of the OMT is its ability to function as a comprehensive physiological stress test. It removes external substitutes and forces the brain to manufacture and release its own ACTH under pressure. Historically, older multi-day versions of this test were considered difficult to manage. Today's optimized single-dose protocol delivers high diagnostic precision in a single night. By directly challenging the communication line from the brain down, the OMT provides a tool for differentiating partial from complete ACTH deficiency. Accurate interpretation of the OMT requires a pre-test preparation phase. Clinicians must eliminate exogenous pharmacological variables weeks before the test begins. Specific medications that affect pituitary or adrenocortical function, such as anticonvulsants, oral estrogens, and exogenous corticosteroids, must be discontinued for at least 5 half-lives. There is also a specific drug interaction regarding acetaminophen. Taking Tylenol concurrently with the test is prohibited, as Metyrapone alters its metabolism and increases the risk of toxicity. The most vital safety step occurs before the OMT is scheduled. The clinician must verify that the patient has already passed a standard Metyrapone stimulation test. This requirement is a safeguard against administering Metyrapone to a patient who actually has primary adrenal insufficiency, also known as Addison's disease. Metyrapone intentionally suppresses cortisol. If a clinician suppresses cortisol in a patient whose adrenals are already failing, they will trigger an immediate acute adrenal crisis. The pre-test optimization phase ensures a proven adrenal safety net is in place before initiating chemical suppression. The active administration of the modern protocol requires a specific timing window, between 11 p.m. and midnight. The patient takes an oral dose of Metyrapone, calculated at 30 milligrams per kilogram of body weight, with a maximum cap of 3 grams. This dose must be administered alongside a snack or milk. The food intake ensures steady gastrointestinal absorption and mitigates the nausea that affects approximately 10% of patients. At the microscopic level, the metyrapone molecule tightly locks onto its specific receptor to initiate the pharmacological intervention. This biochemical pathway demonstrates the mechanism of action. Metyrapone selectively inhibits the CYP11B1 enzyme in the adrenal cortex. This enzyme is the finishing tool for steroidogenesis. Blocking it prevents the precursor molecule 11-deoxycortisol from converting into mature cortisol. Because the conversion pathway is blocked, systemic serum cortisol levels drop throughout the night. This sudden suppression breaks the negative feedback loop. The hypothalamus and anterior pituitary detect the low cortisol levels and enter an emergency state. The pituitary mounts a compensatory response, dumping endogenous ACTH into the bloodstream to resolve the shortage. The adrenals ramp up production, but because the finishing enzyme is blocked, the process backs up, causing a diagnostic accumulation of the trapped precursor, 11-deoxycortisol. The midnight dose effectively turns the HPA axis into a closed pressure system. It forces the biological evidence of a pituitary response to back up into the bloodstream where it can be measured. Precisely 8 hours post-dose, at 8 a.m., the diagnostic window opens for the clinical team. A single blood draw is taken to measure 3 mandatory analytes simultaneously: serum cortisol, 11-deoxycortisol, and plasma ACTH. At this 8 a.m. mark, the patient is intentionally experiencing low cortisol. As a result, they may present with transient dizziness or brain fog. To counter this, clinicians administer a safety dose of hydrocortisone immediately after the blood draw to reverse the induced suppression. The morning protocol operates as a tactical maneuver, capturing diagnostic data at the exact trough of biological suppression, followed immediately by pharmacological rescue. Interpreting the laboratory results requires a 2-step validation matrix to avoid misdiagnosis. Step 1 uses the x-axis to verify CYP11B1 enzyme inhibition. The success threshold is clear. Serum cortisol must fall below 5 micrograms per deciliter, proving robust enzymatic blockade. Conversely, if cortisol reads at or above 8, the test is formally declared invalid. An invalid test means the drug failed to suppress the system. This often points to clinical realities like poor gastrointestinal absorption, undetected vomiting, or accelerated drug clearance caused by interacting medications. This creates a diagnostic dependency. If the cortisol blockade failed, analyzing the precursor data is clinically meaningless and risks an incorrect diagnosis. Step 2 interprets the diagnostic accumulation of 11-deoxycortisol on the y-axis, assuming a valid cortisol blockade. An intact HPA axis responds by surging 11-deoxycortisol to 7.0 micrograms per deciliter or higher. If it remains below 7.0, the test is positive for secondary adrenal insufficiency. This failure occurs because the compromised pituitary gland either could not detect the low cortisol levels, or it failed to mount the ACTH response required to drive steroidogenesis. Clinicians will also check supplementary markers. Verifying the sum of both analytes exceeds 16.5 is helpful, but plasma ACTH alone is too erratic to serve as a standalone diagnostic metric. By testing the brain's ability to communicate under pressure, the specific location of the central defect snaps sharply into focus. Combining strict patient optimization with a dual threshold interpretation matrix allows the modern OMT to identify the specific central failures often missed by standard stimulation tests.